Tall stature, good or bad? The topic for the day on the Steered platform, an educational initiative by my teacher, Dr. Y.K. Amdekar, and I am Dr. Sridhar Ganapathy, a practicing pediatrician from Mumbai who will take you through this topic. So, the first question is, what is tall stature? Tall stature is considered when your height standard deviation score is more than two times the mean for age, sex, ethnicity. And you need to follow the growth charts of that particular country. It's also considered to be tall stature when your height SDS is more than the target height SDS, that is, when you take the mid parental height by a factor of 2. Some consider it as a factor of 1.5. So, when you are taller than the rest in the class, or when you are taller than most of the members in the family and you don't fit the bill. We also take into consideration when we look at tall stature growth acceleration, because there are a lot of conditions in which there is growth acceleration which ultimately leads to tall stature, but in most of them it comes back to normal height because they end up with a genetic potential. So, in order to understand the genesis of tall stature, you need to understand growth or linear growth. So, there is an intrauterine period where it is maternal health, placental health, a lot of play by the environment, insulin like growth factor. The first 2 years where it is all nutrition, but the thyroxine and the growth hormones start coming in. A childhood period that occurs between the infantile and prior to your pubertal spurt, that is before 6 or 8 years, wherein it is basically the growth hormone IGF axis, thyroxine, and a little bit of play by the androgens, the glucocorticoids, the sex steroids, the leptin, ghrelin, and the other hormones. And the last would be a pubertal phase, wherein you have an interplay between the sex steroids and growth hormone and IGF axis. Now, when you look at the causes of tall stature, you have primary causes, which are most of them are syndromic. So here the child doesn't look normal, he's got dysmorphology. There is overgrowth syndromes in a number of them. They are disproportionate, some are proportionate. They have an increased risk of malignancy. They have intellectual defects. They have developmental delays. Some are autistic. And these are called as syndromic tall stature. And under this category, you have the Sotos, the Weaver, the Simpson, Golabi, Behmel. You have the Fragile X, you have the Beckwith-Weidman. You have the marfanoid featured ones like Marfan's, homocystinuria, the Klinefelter, the triple X. Then you have the secondary causes of tall stature, which are usually endocrinal. And here it could be an excess of growth hormone, thyroxine, sex steroids, androgens, familiar glucocorticoid deficiency. It could be an aberration in estrogen receptor function and aromatase enzyme. And you have a third category wherein it's idiopathic. I don't know. And here you have the familial tall stature and the constitutional advancement in growth. In the secondary, don't forget, obesity is now coming up to cause a lot of growth acceleration and a tall stature in the mid childhood. But the ultimate height attained is the growth potential or the genetic potential of the child. The measurements that we do take when we assess tall stature is birth weight, birth length, head circumference, upper segment, lower segment ratio, arm span. We also look at the family history, wherein we take the mid-parental height. We also ask them about the onset of puberty, when the dad shaved for the first time, mummy had her first menses, and we need to plot it on a growth chart. So we do come across growth curves, and there are about 4 or 5 different types of growth curves that we see in tall stature. And let me describe them for you. The first one is wherein the child is born long and he grows along the higher centiles, and he goes way beyond the 97th centile, and he's tall, his parents are tall, that is familial tall stature, without any physical signs of abnormality or intellectual abnormality or dysmorphism. The second one is where a child starts growing towards the end of the first or second year and keeps growing, cutting across centile, and goes way beyond his genetic potential. And that could be an aberration in the growth hormone IGF axis. The third variety is wherein you start normal and you pick up growth in the second year and you pick up cutting through centiles. And by the time you have reached your 8 years, you get back into your normal growth channel and ultimately stop at your growth potential. There might be a little bit of advancement of bone age and a little early puberty. This is called as constitutional advancement of growth. Similar to this is obesity, wherein the extra nutrition causes you to catch up growth, cut across centiles in the childhood period. By the time you reach 7, 8, you get back into the normal growth channel and you end up with your target height, and you're not very tall. Then comes another one wherein you suddenly pick up prepubertal and you cut across centiles, and then you suddenly stop growing and you fall below your target height. And we all know that could be a precocious puberty. The last one is wherein you continue to grow and you grow beyond adolescence into adulthood. There is no increase in the growth velocity, and this could be hypogonadism. So, in the assessment of tall stature, the next step would be to assess pubertal and skeletal maturity. So we use the Tanner staging and we use the orchidometer. So if you have a Tanner stage 2 for the breast or an orchidometer which shows a testicular volume which is significant, you know there is early puberty. And for the bone age, we usually take the X-ray of the non-dominant hand, some even prefer the knee, and we have atlases and charts which could give us an idea of the bone age and also the predicted adult height. And now it's not just the GP, that is the Grulich Pile or the Bailey Penau or the Tanner Whitehouse atlases that we use, but we also incorporate AI, and we have something called as the bone expert, which gives you a predicted adult height. And this could be useful when you have a 1:1 discussion with the parents of the tall kid. So that's about bone age. Now coming to pubertal age and bone age, you also need to understand that we need to create an algorithm so that it makes us easy to come to a diagnosis of tall stature. So in this algorithm, what we do is we first look at the child with tall stature. Is he dysmorphic? Does he have intellectual instability? Does he have developmental issues? Then we go to the syndromic variety, and the syndromic variety can be divided into proportionate and disproportionate. The proportionate ones are like Soto's, Weaver, Simpson, Gulabi, Behmel, Fragile X, and the disproportionate ones could be Marfan's, homocystinuria, Klinefelter, the Beckwith-Widram syndrome, wherein you have a hemihypertrophy. So that's how we divide. And in this category itself, macrocephaly is seen with Soto's and Weavers. You see supernumerary nipples with the Simpson, Gulabi, Behmel. You see vascular anomalies with Proteus. And you have the increased arm span in Marfan. You have thromboembolic episodes and intellectual problems in homocystinuria. You have Klinefelter with lack of secondary sexual characteristics and gynecomastia and being prone to breast cancer. You have Beckwith-Wedman with hypoglycemia in the neonatal period, macrosomia, macroglossia. So there are features which will tell you the syndromes and makes it pretty easy. Overgrowth syndromes in utero. And when you come to a child who looks normal and is tall, you look at pubertal status. If the pubertal status is advanced, it is precocious puberty, exposure to sex steroids, or there is precocious puberty which is gonadotropin dependent or independent. Then you have a puberty which is delayed, which could be anything that gives rise to hypogonadism. And then you have a puberty which is normal, in which we look at growth velocity. If the growth velocity is high, you know it could be growth hormone IGF axis in excess, working in excess, a thyroxine in excess, and very few cases of constitutional advancement of growth and obesity, wherein they usually hit only their genetic potential. And if the growth velocity is bang normal, again you think in terms of familial tall stature. But you could also have it in aromatase and estrogen receptor aberrations. So that's the way we go through an algorithm. Now, coming to treatment, the treatment has to be very specific when it is a growth hormone IGF axis excess, a thyroxine excess, or if it is something to do with precocious puberty. And nowadays, we are even seeing uh, doping or people taking growth hormone in suboptimal doses to improve performance in athletes. And we have tests for that also. Whereas, if at all you want to reduce height, the two modalities that are used maximally are the use of sex steroids and a destruction of the epiphyseal plate at the level of the lower end of femur or the upper end of tibia, what is called as epiphysiodesis, which is done through a percutaneous technique, and the complications are almost negligible. Sex steroids, yes, they come with a big package of side effects. You can have aggression with testosterone, you can have infertility, you can have a predisposition to malignancies. Why is it that we are talking about tall stature? Because being tall also has its other side or the side effects, that is, getting the right clothing, the footwear, fitting into the chair, fitting into a vehicle, getting a life partner. And when you exceed 2.5 standard deviation score or 3 standard deviation score, you need an intervention. And when you are syndromic, it has to be picked up early to prevent the complications that come along with it. Thank you.